Good evening, everybody, and a warm welcome to our webinar this evening. My name is Julia Priestley, and on behalf of the BTF, I'd like to welcome you to the latest in our series of Meet the Thyroid Expert webinars. Today's topic is highlighting something which is of huge importance to many women and families, and we know that many of you have questions that it's not always easy to find the answers to. An undiagnosed or uncontrolled thyroid disorder can make it much harder to get pregnant, and it can also increase the chance of miscarriage and harm of the developing baby. So it's therefore essential that thyroid disorders are well managed during and after pregnancy. To help women receive their very best care, the Royal College of Obstetricians and Gynecologists, or the RCOG, has published a new Green Top guideline on the management of thyroid disorders in pregnancy. And in tonight's webinar, we're delighted to introduce to you two of the doctors who led the way in developing these new and important guidelines. Professor Xiao In Chang, who's a consultant obstetrician in Singapore, who joins us this evening, and also Professor Christine Bollard, who many of you will recognise, who's a consultant endocrinologist at the University Hospitals Birmingham, and also the current president of the British Thyroid Association. Both of our speakers were involved in writing the new RCOG guideline and will provide an overview of its recommendations to you all. And as well as doing all this research and writing of these guidelines, they look after women with thyroid disorders every day, so they know as well as anybody else the concerns that there are and how to manage them. So during their presentations, please type any questions you have into the Q&A, and we'll do our best to ensure that they can all be answered. Obviously, our speakers won't be able to answer any specific medical questions, but if you've got any particular concerns about your own health, please contact your own doctor. Today's session is being recorded, so you'll be able to watch it again in your own time or share it with anybody who may be interested. It will be available on the BTF website in a few days' time and on our YouTube channel. So without any further from me, I'd like to hand you over to Professor Chan, and I'll stop my share and get up their presentation as well.
Okay, good evening, everyone. I think somebody's going to bring up some slides for me.
Yes.
Okay, it's coming.
Let's get to the beginning.
Can we start from slide 1?
You see that now?
Yes, okay. All right, I think we can move on to the next slide since Julia has made such a good introduction. So as she said, the Green Top guideline by the RCOG was published earlier this year in April. And both Christine Bollard and I have been heavily involved in developing these guidelines. So we're very pleased this evening to share this with you. And hopefully we'll make it simple and relevant and applicable to your situation. Okay, next slide. So just an outline of where we're going with this. So I'm just going to give you a brief overview of what thyroid hormones are in pregnancy and what they do. Then we'll talk about screening for thyroid disorders, and then an underactive thyroid, borderline thyroid function, thyroid antibody positivity, and then an overactive thyroid and post-delivery thyroid abnormalities. Okay, next slide. So thyroid hormones actually change a lot during pregnancy. So in pregnancy, thyroid demands go up and thyroid hormone production increases by about 50%. And this increased requirement starts very, very early on during the pregnancy. And it also means that women need more iodine during pregnancy because iodine is important to make thyroid hormones. The pregnancy hormone, HCG, that is what gives you a positive pregnancy test. That particular hormone actually stimulates the thyroid gland to produce more thyroid hormones and to help the body keep up with this increased thyroid hormone requirements. So there are two thyroid hormones that are normally measured, and you would, if you've got thyroid disorders, you would know. There's a thyroid stimulating hormone, which is the TSH, and the free thyroxine, which is the free T4. And these both change a lot during pregnancy, particularly in the first half of pregnancy. And because they change so much, when we do thyroid function tests in pregnancy, we have to use trimester-specific reference ranges, which are specific for particular parts of the pregnancy. And most of these thyroid function changes actually occur before 20 weeks of pregnancy. Next slide. And you can see in this graph here that the HCG peaks at about 10 weeks, the free T4 goes down, TSH goes down, other hormones go up. And you can see that most of these changes actually happen in the first 20 weeks. After 20 weeks, these hormones more or less stabilize till the end of pregnancy. So that is why in the first half of pregnancy, more frequent thyroid function tests needs to be done in women with thyroid function disorders. Next slide. So the trimester-specific reference ranges that I was talking about is very different depending on which manufacturer the lab uses, which machine the lab uses to measure the thyroid function. You wouldn't need to know this, but this is just for your information, just general information, okay? So you know that ranges that are from one lab cannot be applied to tests done in another lab, for example. So you always have to interpret the thyroid function using the ranges that are given for that lab, for that test, okay? So you can see here, for example, if you look under Beckman excess in the first trimester, the TSH normal range goes up to about 3.32. I don't know whether you can see my, you probably cannot see my arrow. And if you compare it with the Roche-Cobas, the upper limit goes up to about 4.1. And then if you compare the first trimester and the third trimester, you can see for the Beckman excess, the upper limit in the first trimester is 3.32, and in the third trimester is 5.02. So this is not for you to remember or to memorize, but it's just to let you know that there can be differences with different manufacturers and over different phases of pregnancy. Next slide. So thyroid hormones are important in pregnancy because they are needed for normal fetal and placental development. And this is especially so in the first half of pregnancy. In the first half of pregnancy, the brain development of the baby is dependent solely on maternal thyroid hormones because the baby doesn't produce any of its own hormones until 18 weeks of pregnancy. So it's very important in this first stage of pregnancy to maintain normal thyroid hormone levels. Too much or too little thyroid hormone can increase complications such as difficulty in conceiving. And when you conceive, there's a higher risk of miscarriage, pregnancy loss, high blood pressure in pregnancy, preterm birth, and poor fetal growth. But generally, if your thyroid function is well controlled and adequately treated, then pregnancy outcomes are more or less similar to those of the general healthy population of women. And just as a note, in most cases, breastfeeding is safe. Your thyroid disorder should not stop you from breastfeeding the baby. Next slide, please. So I'll hand over now to Dr. Bollard to go through who should get tested.
Thank you, Xiao, and welcome everyone. So yes, and I think there's already a question about this in the chat, who should get tested? And this is an age-old argument that keeps going around where people think, should every pregnant woman be tested for thyroid function? So for this guideline and for many other guidelines, the evidence has been very clearly reviewed. And the recommendation is clear that not every pregnant woman should have their thyroid function or their thyroid antibodies tested. There is no evidence and that by doing this, you would improve the overall outcomes of the general population. However, there are, sorry, next please. Thinking I could drive this myself. However, there are certain groups of women who will be at a higher risk of developing abnormal thyroid function during pregnancy. And if you are in one of those at-risk groups, then it is appropriate for your doctor to do a blood test to check that your thyroid levels are in early pregnancy. And our guidelines, next slide, please, give a clear overview of who these particular subgroups are. So this concerns women who have a personal history of a thyroid condition or a previous insult, women who have other autoimmune conditions. So most thyroid disease in women of childbearing age is autoimmune in nature. So if you have other autoimmune conditions such as type 1 diabetes or antiphospholipid syndrome, then it is appropriate to do a thyroid function test before you become pregnant or early in pregnancy. And if you've had a late pregnancy loss, either a stillbirth or a pregnancy loss in the second trimester. So this means that not everyone who has had a single first trimester loss should have their thyroid function routinely screened. The first group is probably the largest group. So those are people who have previously had an insult to their thyroid gland. They've had previous thyroid surgery. They've had a thyroid nodule. They've had a previous inflammation of the thyroid gland. They are on medication that may interfere with their thyroid function, or there are very specific signs and symptoms that point towards there possibly being a thyroid condition present. I think before we go to the next slide, we will just take a few questions. There are already some in the chat that I can see. I'll answer the first one because, and thank you, it's great to have these new guidelines. How will you be letting GPs know about this? But I'm pleased to tell you that in 2 weeks, on the 16th of September, we are having a specific GP webinar, which we're doing together with the MIMS platform, which is specific for GPs, which has already got more than 410 GPs registered. So hopefully we will get the message out there. I think you're right that many GPs are not fully versed with how to manage this. And hopefully our webinar will shed some further light on this for them and encourage them to read those guidelines or look things up if they need to do so. Maybe I'll ask Xiao the second question, which is, I'm not sure whether this is specific to thyroid or whether this is a general question. Would you recommend freezing eggs?
Egg freezing is a entirely different matter. I don't think it relates to the thyroid gland. A lot of women are freezing eggs for other reasons. For example, they are undergoing some kind of medical treatment that requires them to freeze their eggs, or because of age. The thyroid really doesn't, it's not one of the indications. Next question. Can women have children because of thyroid disorders? Yes, they can have children, but the chances of conceiving and having a successful pregnancy outcome are higher if the thyroid function is well controlled. Thyroid disorders is just one of very many reasons why women have difficulty conceiving or have problems in pregnancy. So if you've got an issue, please go and see a doctor so that you can be tested for these. Last question. Okay, I think that will be covered in the next part of the talk. So maybe we should move on.
I just wanted to add to the last, which is about, are there many instances of women not being able to have children at all because of their thyroid disorders? You know, there's certainly lots of evidence that significantly abnormal thyroid function affects this, as Xiao has said. Is your question now, can we find out if we're affected? I think we've tried to answer that by saying not everyone who is pregnant should have a thyroid function test, but if there is a specific reason why, or if you have any symptoms. So most of those conditions that really result in women not being able to have children will present themselves with symptoms or other signs. And in those cases, it's then important that a thyroid function test is done. But maybe we'll move to the next slide so Xiao can get on with the hypothyroidism section.
Okay, so now we'll move on to the underactive thyroid part. So underactive thyroid is defined as women who've had a TSH that is above the reference range and a free T4 that is below the reference range. And these women are usually diagnosed before pregnancy, and they are already on levothyroxine treatment. If the condition is not treated or inadequately treated, there can be difficulty conceiving, increased risk of miscarriages, pregnancy loss, high blood pressure, premature birth, and small babies. And in some cases, the brain development of the baby can also be affected. But if you're adequately treated from preconception onwards and right through pregnancy, then you can expect to have similar outcomes with the general healthy population. Okay, next slide. So let's go through a case. 28-year-old woman diagnosed with hypothyroidism 2 years ago. She's treated with levothyroxine 100 micrograms daily and is stable. And for the last 18 months, the thyroid function tests have been normal. And her last one was a year ago with a TSH of 2.9, well within the reference range, and a free T4 14.3, also well within the reference range. And she would now like to become pregnant. What should she do? Next slide. So before I move on to the next slide, just general preconception advice. You need to start taking folic acid supplements at least 3 months before you start trying to conceive. Stop smoking, stop drinking, and adopt a healthy diet and lifestyle. Okay, next slide. So before pregnancy, she should see her GP, get her thyroid function tested, and have the dose adjusted to try to get a TSH that is below 2.5. Because if she's adequately replaced with a TSH less than 2.5, then she's less likely to develop low thyroid hormone levels when she becomes pregnant, because pregnancy increases the thyroid demand. Okay. If after 6 months of that test, she still hasn't conceived, she should have a repeat thyroid function again to make sure that it remains below 2.5. After 1 year, if she hasn't conceived, she should start discussing with the GP whether she should be investigated for other causes of difficulty conceiving. Okay. As soon as she has a positive pregnancy test, she should increase her dose of levothyroxine. Now, you don't need to wait to see a doctor to do this. As soon as you see a positive pregnancy test, just double up your dose on 2 days of each week. So pick 2 days that it's easy for you to remember. For example, Mondays and Fridays or Tuesdays and Saturdays. It doesn't really matter. Just double up the dose on 2 days a week and then arrange to see your GP as soon as possible. The first thyroid function test in pregnancy should ideally be done by 7 to 9 weeks of pregnancy, okay, as soon as possible. And further dose adjustments may be required, either up or down, again, trying to target the TSH between 0.1 and 2.5. And we want to maintain the free T4 levels within the normal trimester-specific reference ranges. Typically, the frequency of thyroid function should be checked every 4 weeks during the first 20 weeks of pregnancy because of those dynamic changes that happen. And then once it's stable after 20 weeks, you just need to get it checked again at 28 weeks. Usually, we would recommend a thyroid function test 4 weeks after each dose change. After you have the baby, 2 weeks after the birth, you can return back to your usual thyroxine dose that you were taking before you got pregnant. Okay, next slide. Okay, so now let's go through another case. So this is one of a borderline thyroid function at 7 weeks of pregnancy. So it's a 33-year-old woman who previously had a transient borderline hypothyroidism 5 years ago. That means an elevated TSH, but a normal T4. On repeat testing, it resolved on its own, so she wasn't too worried. And her last thyroid function test was 2 years ago, which was normal. So she's now pregnant, and she's 7 weeks of pregnancy, and she's one of those women who should be screened based on the list that Christine shared just now. So the GP ordered a thyroid function test, and now it shows that the TSH is elevated, 8.9, which is above the upper limit of 4 in pregnancy, and a free T4 is still normal, 12.3. Okay, next slide. So what should happen now? Right, borderline underactive thyroid is actually not that uncommon. As I said, it's a TSH that is above the upper limit of the reference range, but below 10, with a free T4 within the reference range. And the treatment is only required, the treatment with levothyroxine is only required if you're planning pregnancy or if you are pregnant. And if it is not treated, there is a risk that it can progress on to overt hypothyroidism. Especially in pregnancy, the risk of progression is much higher. And the pregnancy risks are similar to those of hypothyroidism that I outlined just now. But if you're adequately treated from preconception onwards or from the first trimester onwards, then the outcomes are similar to the general healthy population. After the delivery of the baby, she can stop the levothyroxine because her thyroid function might have returned back to normal and have a thyroid function rechecked at 6 weeks. There are certain circumstances where the doctor may not give you levothyroxine treatment in subclinical hypothyroidism, especially those cases which are detected in the second and third trimesters of pregnancy, because in clinical trials, starting treatment at that stage of pregnancy actually didn't change any of the outcomes. So if it's detected late in the second and third trimesters, all that's required is monitoring to see whether overt hypothyroidism develops, in which case then levothyroxine should be started. Okay, next slide. Should we pause for questions or should I just push on? I can see those questions building up.
I think maybe we should take some questions because they're building up too much. The first question I think has been answered. Will you need to adjust the dose of levothyroxine once you conceive? So as Shara said, the standard advice is double your dose on 2 days of the week once you find out you're pregnant, and that is then usually followed up with relatively soon thyroid function tests so that a more adjusted dose increase can be done, but even if you slightly overdo it, that's less dangerous than not having enough. So double it on 2 days of the week once you're pregnant. The second one is relatively specific. Shao, do you want to take that one?
I don't know which one you're talking about.
So Rachel Lob-Levitt.
Okay.
Should you take any other supplements if you've been diagnosed with hypothyroidism, treated with levothyroxine and struggling to get pregnant? I mean, obviously,
if you've had unprotected sexual intercourse for 1 year and you still haven't conceived, then you should go and see a doctor because they might need to do other tests to find out whether there's anything else that needs to be addressed apart from the thyroid. And in general, if you take prenatal supplements containing folic acid 400 micrograms, that is generally helpful. Whether that will help you conceive is a different matter, but it can address any potential subclinical micronutrient insufficiencies. If you're diagnosed with Hashimoto's and successfully treated with thyroxine, I'm just reading out the question. Okay, IVF. Okay, can IVF help with recurrent miscarriage? Well, it depends what the reason is for the recurrent miscarriage, okay? If the recurrent miscarriage is caused by thyroid problems, then IVF won't help. We just need to manage the thyroid problem better. But if it is due to something else, for example, a chromosomal abnormality, genetic abnormality, then IVF could be helpful, and you should discuss that with a doctor.
Coming back to the second part of the question, if you're diagnosed with Hashimoto, I think, so Hashimoto is just a condition where you have antibodies to the thyroid gland. Shah will come back to TPO antibody positivity. And, if you're already on levothyroxine, then, what should happen is to have the right dose of levothyroxine and have your thyroid function in the target range. There isn't really anything else that you can do, but Shah will come back to that. So the next question is what TSH and T4 would count as being well controlled. I think again, Shah has answered that. So we aim for a serum TSH below 2.5 if you're being treated before you conceive and during pregnancy. The next one is about a man having a thyroid disorder. Shah, do you want to take that?
Yeah, well, the evidence is not so strong for men, but there is anecdotal evidence that thyroid disorders can affect sperm counts. I mean, if you're worried about your husband, then he should go and get tested. Yeah,
exactly. So we wouldn't routinely treat a TSH. The next question is, does a TSH of 3.8 need to be treated preconception? We wouldn't routinely treat that. Since that TSH is probably towards the upper limit of normal of many pregnancy-specific reference ranges, and especially if you're TPO antibody positive, we might, and that's what the fertility guideline recommends, is that those patients, if you know that they're TPO positive, that we might do a thyroid function test in the first trimester to make sure it hasn't got worse. I'm not quite sure whether the next one is a question. It says, as a fertility reflexologist, I had a client who has underactive thyroid, has gone on to have 2 babies. Yes, most of our patients with hypothyroidism successfully go on to have babies, so that's excellent. Do you want me to take the adrenal insufficiency one?
Yes,
So
yeah.
if you have evidence of adrenal, so the question is, if you have evidence of adrenal insufficiency from exogenous steroid inhaler, is there risk of adrenal crisis with thyroid replacement? So if you have evidence of adrenal insufficiency, you should be on hydrocortisone replacement. If you also need thyroid replacement, then, as long as you're replaced on hydrocortisone adequately, then, there shouldn't be a problem. I think is the answer to that question. Is it safe to double the dose if you're on 75 micrograms? Yes, it is safe to double that on 2 days of the week.
It doesn't matter what dose you're on. It's safe
Exactly.
to double it on 2 days a week.
Do you want me to take the next one as well? Because that
Yep.
is actually a very good question. If do things differ if someone has had a thyroidectomy due to papillary thyroid cancer and is already, because of patients with thyroid cancer, especially if they have had a sort of a more aggressive cancer or are in the early stages following their treatment, they may artificially have a low TSH in order to prevent the growth of thyroid cancer. So they're already on higher doses than women who don't have thyroid cancer as an underlying problem. So in those patients, especially if serum TSH is already suppressed, if I get asked about that, I often say, don't double it. We will do a thyroid function test because, you have some leeway there because that TSH is already very, very low. And you also don't want to sort of artificially completely overdo it. A little bit of overdoing it, like I said, is not so problematic. But yeah, that's a specific patient group where I think endocrine advice is needed, and where often we will say, let's have a thyroid function test and make a decision.
Okay, so I think there's a misunderstanding here with the next question. So you don't double the dose to increase the chance of pregnancy. You only double the dose on 2 days a week after you have a positive pregnancy test, not before. Okay. And after you deliver your baby, you go back to the dose that you were on before you got pregnant. It can be the dose that was keeping your TSH below 2.5, because after you go back to that pre-pregnancy dose, you will need a thyroid function checked anyway, about 6 to 8 weeks after your baby. So it will tell you whether you're on the right dose. Okay. PCOS. Okay.
I think the answer to the question is if you're on adequate replacement with levothyroxine. I don't think from our point of view there's anything else you could do. You've had 5 IVF. I'm sorry to hear that it's so difficult, but you've had 5 IVF attempts. It sounds like you're on the right treatment, and this is for a fertility specialist really to advise further. But I don't think there's a natural thing that you can do. It is making sure that your TSH is in the target range and that the treatment for PCOS is optimized.
I'm not quite sure what the next question is referring to.
Understand
So
it either.
levothyroxine will change the TSH and free T4 that is measured in the blood. Yeah, levothyroxine will affect both of those 2 hormones. 150 microfarad. So if you're on levothyroxine and your thyroid function is normal, it doesn't matter how high your TPO antibody is. The important thing is keeping the thyroid function normal. Should we take anything else apart from folic acid in supplements? Like I said, if you have prenatal supplements that contain other vitamins as well as folic acid, that's fine. That's good. I've lost track of where the... Are we more or less done? Oh, okay. My GP
so there is one here.
slightly hyperthyroid.
Yeah.
Okay. Yeah, you can get pregnant with that thyroid function test. And again, whether you should double up your dose once you get pregnant, maybe just double up on one day of the week and then get your thyroid function tested again. But I think you need to discuss this with your own doctor. Christine, what do you think?
Yeah, I mean, I think the previous case of someone with thyroid cancer where TSH is really less than 0.1 and suppressed in our books, definitely, you know, there I would be a little bit more nervous. This is only a slightly low TSH. And I think, again, as Xiao says, a thyroid function test early on in pregnancy here will be very informative. I don't think you'll be doing massive harm by doubling it on 1 or 2 days of the week. But have your thyroid function checked once you become pregnant.
If you have a TSH of 2.8 and a strong family history and you're having symptoms, I mean, if you have your thyroid function checked and it's normal, then it's not the thyroid that is causing these symptoms. It could be due to other things. Christine?
Yeah, I'm not quite sure what's meant by a thyroid panel. You've had a TSH. It seems that the TSH is normal, so that's your screening tool for you know, abnormal thyroid function, and at 2.8, that is normal. You are at higher risk of at some point in life developing hypothyroidism because of a family history. The link with chronic fatigue is more tenuous. Yeah, I think having a TSH of 2.8 effectively indicates that your thyroid status is normal. Adrenal insufficiency, I'll take that.
The second one you've addressed, isn't it? The adrenal insufficiency and thyroxine one. And then the last one, postpartum thyroiditis, you're going to talk to that later. Yeah. Okay. Fine. So should we move on with the talk? Yeah.
Indeed.
Okay. I think for some reason a few slides have skipped. Can we go back to the TPO antibody slide 2 slides ago? Yes. Okay. So let's talk about thyroid antibodies now. 34-year-old woman she had a series of tests performed because she had difficulty conceiving, and one of those tests was thyroid function test and TPO antibodies. And these are her results. Her thyroid function is completely normal, TSH within the normal range, free T4 within the normal range, but her TPO antibodies are elevated above the normal range. So what should she do? Okay, next slide. Okay, so I'm only talking about women who have got a completely normal thyroid function, just that their thyroid antibodies are positive. Okay, the risk is that they will develop an underactive thyroid or hypothyroidism in the longer term, and the risk of them progressing to hypothyroidism is actually higher when they are pregnant because they have the increased thyroid demands. And the risks of having these TPO antibody positivity, even with the normal thyroid function, include premature birth, function abnormalities like postpartum thyroiditis. Unfortunately, the clinical trials that have been done shows that levothyroxine actually does not reduce any of these risks if your thyroid function is normal. So if it is just the thyroid antibodies that are positive with the normal thyroid function, no treatment is required. However, because of the risk of progressing to hypothyroidism, it is important that you are screened and monitored regularly, especially during the time when you're trying to conceive. Every 6 months, you should have a thyroid function test. And when you become pregnant, you should have a thyroid function test by 7 to 9 weeks, so very early in a pregnancy, and then again at 20 weeks. And should those tests show any hypothyroidism, then levothyroxine treatment is recommended. We don't need to repeat the thyroid antibody test. This advice applies no matter how low or high your thyroid antibody level is. Okay, next slide. Okay, I'll pass this over to Christine.
I think there are a few, maybe we just finish off the questions relating to hypothyroidism and antibodies. So I think maybe we haven't answered one of the questions well enough. Once you finish pregnancy, go back to your dose before pregnancy. Yes, we mean the dose before you doubled before you increased, go back to your pre-pregnancy dose, and then generally your GP will do a blood test at about 6 weeks when you go for your postnatal check. I'll take the adrenal insufficiency one as well. How does, if you've already been, sorry, it keeps skipping. With adrenal insufficiency, how does it affect cortisol if you've treated with thyroxine before hydrocortisone starts? Well, so the risk is if you have adrenal insufficiency and you're on neither, that you give levothyroxine before you give hydrocortisone. If you're already on levothyroxine, this is a non-issue. So if you have adrenal insufficiency, you need hydrocortisone. If you're already on levothyroxine, there is no increased risk. We'll come back to postpartum thyroiditis. Relationship between TPO and miscarriage, hopefully Xiao has answered in her slides. So there is a relationship. However, what the trials have shown is that there is no, if thyroid function is normal and antibodies are raised, that there is no benefit from giving levothyroxine. I will take the next question as well, because it's actually not related to pregnancy. So I won't dwell on it. It is not true that TSH is only a good indicator of everything else is working. TSH is your best indicator of thyroid status. Do some people feel better if their free T4 is checked? I don't think checking free T3 routinely when TSH is normal is a good thing, only when TSH is low. But what some GPs will do is check TSH and free T4 to put your mind at rest. And if there is any concern that it might be autoimmune disease, then checking thyroid antibodies, TPO antibodies once, not repeatedly checking this can also be helpful. Do high antibodies mean that the hypothyroidism will get worse? No, is the short answer to that. So we don't manage our treatment based on the level of antibodies that you have. The fact that antibodies are high means that there is an autoimmune reaction going on, and could that indicate that at some point things worsen? You will have your thyroid function checked regularly and the dose of levothyroxine adjusted. But so repeatedly checking antibodies and trying to make judgments based on antibody levels has not been shown to be an effective way of doing this. So coming back again, how to get more than TSH with GP, I believe that that's not a question related to pregnancy, and I've already tried to give an answer to that. And I'll give Xiao the last question. Any other conditions that you could develop as a result of being hypothyroid during conception and pregnancy?
I'm not quite sure what this means. You mean complications in pregnancy? I think we have more or less outlined the complications. Yeah. It doesn't happen to everybody, clearly. Risks are risks, but complications don't happen to every single case.
And I think the issue that we've tried to underline repeatedly is that with good control, the risk of significant complications during pregnancy for both mother and baby are very much reduced. So this is all about getting as good control as possible. So I think those are we'll come back to the other questions because I think we'll move on with the hyperthyroidism bit. If there are any questions that are still unanswered, we'll try and answer them as best as we can. But so this is, we're now moving to the other side of the spectrum. So this is an overactive thyroid gland. A 30-year-old woman who was diagnosed with Graves' disease a year ago. She's on treatment with the typical drug that we give to patients with Graves' disease, carbimazole, something that blocks the thyroid function, and she has normal thyroid function, and she would like to become pregnant. Next slide, please. So the things to consider are, what this cartoon on the right here illustrates is what Graves' disease is. So Graves' disease is the most common reason for having an overactive thyroid gland in women of childbearing age. And essentially what happens, if you look on the right-hand side of the slide, you see those TSH receptor antibodies that are sitting there on the TSH receptor, and they cause the Graves' disease because they essentially make the thyroid gland produce more and more and more and more thyroid hormones. If hypothyroidism is uncontrolled, then there is a higher risk of complications, very similar to hypothyroidism, really. It's all about having good control. And the risks associated with an untreated or an inadequately treated overactive thyroid gland are high blood pressure in pregnancy, that the baby is of lower birth weight, and then problems with attention deficit hyperactivity disorder or autism. So like I've already said, good control is really very important here. Ideally before someone becomes pregnant. Next slide, please. So the treatment options for Graves' disease on the left-hand side, so that is anti-thyroid drugs, and that will be the most common treatment for women of childbearing age, certainly if they're trying to become pregnant. There is radioactive iodine or there is surgery. And I'll just talk a little bit more about those on the next slides. Next, please. So if you have an overactive thyroid gland, and the chances that you wish to become pregnant in the next 6 or 12 months, then you need to discuss the risks of the various treatment options with your doctor. If you decide to go for radioactive iodine, which will be a more what we call definitive cure than anti-thyroid drugs, then you're expected to wait at least 6 months after the radioactive iodine to become pregnant, because the radioiodine may damage the unborn fetus. But also what you have to bear in mind, those antibodies that I was talking about with Graves' disease, after radioactive iodine, they may go up. And if you have high levels of antibodies, that can be a problem during pregnancy. So therefore, radioiodine needs careful consideration with your endocrinologist, certainly if you're trying to become pregnant in the next 6 to 12 months. If you've had thyroid surgery, so your thyroid gland removed, then ideally we'd like a stable thyroid function. So 2 normal thyroid functions 3 months apart, showing that thyroid function is within the required reference range. So this will be the normal non-pregnant reference range. Next, please. So we do measure, and I'll come back to when to measure TSH receptor antibodies in women who've had Graves' disease. But if they remain significantly raised, then generally that's considered to be 3 times or more the upper limit of normal of the assay that's present in where you are. And if that is the case 6 months after definitive treatment, then generally you may be advised to wait a little bit longer for those antibody levels to hopefully come down. And because those raised antibodies can cause overactivity in the unborn baby. So from 20 weeks, as Xiao said, the baby has its own thyroid gland. Those antibodies can cross the placenta and make the baby's thyroid gland overactive, which is not a good situation to be in. Next, please. So a little bit about which anti-thyroid drug. So the patient that I illustrated was on carbimazole, which is the most commonly used anti-thyroid drug. The other drug that we have is propylthiouracil. And essentially, I'm not going to dwell on what these various graphs here show, but carbimazole has been linked to a higher risk of inducing fetal abnormalities. Now, I don't want you to all get really scared, because those abnormalities still occur in less than 1 in 10,000 women who take this medication. But there is currently an MHRA warning out that women trying to become pregnant should use contraception and should ideally not become pregnant on carbimazole. And if someone is trying to become pregnant, they should be changed to propylthiouracil, which is the other drug, which is not completely devoid of abnormalities in the fetus, as you can see in the graph there, but they tend to be milder abnormalities and they tend to be more correctable. So next slide, please. So the recommendation is that if you are planning pregnancy and you're on carbimazole, that this is changed to propylthiouracil. And if you did become pregnant on carbimazole and you're still before 10 weeks, again, that this is changed to propylthiouracil. There is a very clear link that the dose of anti-thyroid drug you take is linked to abnormalities. So therefore, the recommendation is to always use the lowest possible dose. And ideally, we check that thyroid function is normal within 6 months of becoming pregnant, as we've already said. Next, please. Generally, we aim to keep the serum, because what we don't want to do is overdo it with anti-thyroid drugs. So we aim to keep the serum free T4 in the upper half of the normal range. And women who are actively treated with anti-thyroid drugs, so those are women certainly in my clinic and in Xiao's clinic, they get very regular thyroid function tests, 2 to 4 weekly, certainly in the first half of pregnancy. And then usually we may relax that a little bit. You have to bear in mind that Graves' disease usually gets better in pregnancy, and often we can stop anti-thyroid drugs in the second part of pregnancy or even around 16 weeks. Next, please. So that's what I've just said. If anti-thyroid drugs are stopped, then what you have to be aware of that there is a chance of a flare after delivery. So who should get tested? Well, everyone who has ever had a history of Graves' disease should have their antibodies checked at booking. So that's at 12 weeks. And if they are raised at 12 weeks, so 3 times or more the upper limit of normal, they should be repeated at 20 weeks and at 28 weeks. Or if you're still taking anti-thyroid drugs, because at 20 weeks, this is going to determine how closely do we need to monitor the fetus. At 28 weeks is what we determine is how likely is your baby to possibly have problems in the neonatal period. Next, please. So the recommendation is that more regular heart rate auscultation and ultrasound scanning to monitor the growth of the baby should be done in women where antibodies are raised 3 times or more the upper limit of normal at 12 weeks, those who are actively treated with anti-thyroid drugs, or those where Graves' disease was very uncontrolled, especially early in pregnancy. Next, please. So after pregnancy, what happens to women with hypothyroidism? Like I said, it often, we've stopped anti-thyroid drugs, but it may relapse, and it can be difficult to distinguish a relapse of Graves' disease from postpartum thyroiditis in the postpartum period. The aim of treatment following pregnancy is that thyroid function is kept within the normal reference range. And once again, I think Charles already said it, but both levothyroxine as well as the anti-thyroid drugs, they're both safe in breastfeeding. Sometimes what we ask is that women split the dose, so they take, this is certainly, propylthiouracil is usually given more than once a day, but carbimazole may have to be split in 2 doses with people taking their tablet after the last feed in the evening and after the first feed in the morning. If you're on very high doses of carbimazole, then your baby, and you're breastfeeding your baby, may need thyroid function testing. But again, your endocrinologist will be very well aware of this and well versed in this. Next, please. So maybe I'll just do the gestational transient thyrotoxicosis, and then we'll finish off with all the questions that are still in the chat. The gestational transient thyrotoxicosis. So this is a situation where you have a newly presenting overactive thyroid gland during pregnancy. And remember the graph that Xiao showed of the HCG that causes abnormal thyroid function test. Well, so this is very much driven by HCG, where you get thyroid function test changes consistent with an overactive thyroid gland and effects of these increased thyroid hormones without actually the thyroid gland producing or being sick from Graves' disease. Because it's driven by HCG, it's more common in women with severe vomiting or in twin pregnancies. Generally, if this is the situation, it does not require treatment with anti-thyroid drugs and it doesn't put a pregnancy at risk. It's usually a self-limiting condition that settles after the first trimester. If women are very symptomatic from high levels of circulating thyroid hormones, they may need a beta blocker. And so if hyperthyroidism presents for the first time in pregnancy, this is almost certainly this transient condition and not a new presentation of Graves' disease. If you had Graves' disease or symptoms of Graves' disease before you became pregnant, then a differential diagnosis has to be made. And this can be done based on antibody levels on thyroid function testing and is generally done in a specialist clinic. Next, please. So this is the last clinical case. This is a 32-year-old lady who is after birth, 4 months after birth, and has symptoms of an overactive thyroid gland, but no symptoms of Graves' disease, so no symptoms of eye disease. She's noticed that breastfeeding has become more difficult. There has been no previous history. She's not had a history of thyroid problems before and had a normal pregnancy and normal delivery. You can see that she has a very fast pulse and she has lost some weight and her BMI is now 21.3. Next, please. And you can see her thyroid function tests show that she has an overactive thyroid gland. Next, please. So this is postpartum thyroiditis. And essentially what happens in postpartum thyroiditis, and I'd like you to look at the yellow graph or the yellow line on this graph, is that it's biphasic. So it goes in 2 phases. Generally, there's an overactive phase, then an underactive phase. Because what happens is that there is an inflammation of the thyroid gland. The thyroid gland is sick. It releases all its thyroid hormones into the circulation, and then thyroid hormones are depleted, so it then goes through an underactive phase, and then it settles. It doesn't always settle, and some women become permanently hypothyroid, and that's the red line. Sometimes we only catch the overactive phase, and that would be the green line, or sometimes we just catch the underactive phase that can be transient, and that's the blue line. Next slide. So it's important that we differentiate this from Graves' disease, and that is through taking a history, looking for clinical features of Graves' disease. So this patient didn't have any, and through, again, measuring those antibodies and possibly by performing special scans to see if the thyroid gland is overactive. Next, please. So the recommendation is that usually, again, this is a self-limiting condition, and anti-thyroid drugs may not be needed. If women have very symptomatic underactivity of the thyroid gland, when you remember that it went overactive and then it went underactive, if they're very symptomatic during the underactive phase, that levothyroxine can be given to help with the symptoms of that, but it needs very close follow-up, and often levothyroxine can be stopped. If about 50% of women who develop this biphasic postpartum thyroiditis will end up on lifelong levothyroxine. Next, please. So if you don't treat, then monitoring of thyroid function is important. And again, I think this is one of the questions in the chat as well. Is there a likelihood of this recurring? Yes, there is. And again, even if you don't become pregnant again, there is that risk that you develop permanent hypothyroidism. So annual thyroid function measurement is important. Next, please. So it needs to be taken into account that if you've had a previous postpartum thyroiditis, this is likely to occur in the next pregnancy, but also to perform thyroid function test as soon as possible during the pregnancy. But there is no evidence that giving prophylactically levothyroxine or any of those other treatments like iodine or selenium are of any help. I think that is the last slide. Next. Please. That's it. Yes. In which case, we'll go back to the Q&A.
To the questions, yeah.
Yeah.
I think Christine's talk has actually answered most of the questions that are on the chat. So I'm just filtering through. So the ones left open, the first one on thyroid cancer, I think we have addressed that. Recurrent thyroiditis, I think that has been addressed in Christine's talk. Hypothyroidism during and before pregnancy, right? So if you were diagnosed with hypothyroidism only after the delivery of a baby, there's no way of knowing whether you already had it before or during the pregnancy. It might have been something that have arisen after the pregnancy. So if your pregnancy went well and your baby is healthy, then don't worry about it. More things like risk of diabetes. So you were asking whether hypothyroidism can lead to diabetes. I think there is no clear evidence that hypothyroidism leads to diabetes, but there have been studies that have linked the two conditions, but that doesn't mean that one causes the other. It might be that, something else, a paraphenomena, puts you both at risk of hypothyroidism and diabetes. And certainly in terms of autoimmune conditions, if you've got type 1 diabetes and you've got autoimmune Hashimoto's thyroiditis, then those are autoimmune conditions. They can be associated, and that puts you at increased risk of both things. But I don't think there's evidence that the hypothyroidism gives you gestational diabetes, for example, although the conditions have been linked in some studies. Christine, do you want to add to that?
No, I think in relation to diabetes, you've answered it. I think the question above that is I'm just going to read it. My thyroid was originally diagnosed as being underactive and then became overactive. I was ultimately diagnosed with Graves' disease. So it sounds like you had oscillating antibodies. So those antibodies, those TSH receptor antibodies, can either stimulate the thyroid gland, but sometimes they can block it. And we do see this, that women or people have an underactive thyroid gland, treated with levothyroxine, and suddenly they become overactive. And that's because those antibodies can swing between stimulating and blocking. And so you're currently on carbimazole, the dose is being changed up and down, so it sounds a little bit difficult to control your Graves' disease. Would it be better to eliminate Graves' disease by doing radioactive iodine treatment? Well, so I love radioactive iodine treatment. I'm one of the few people in the UK who really love it. In women trying to become pregnant, I am a little bit more worried, especially if they have high levels of antibodies, because they may shoot up. So what I sometimes recommend, and again, we do little surgery for patients with Graves' disease, but someone with difficult to control Graves' disease, high levels of antibodies, who's like, look, I really want to become pregnant, removing the thyroid gland will be the best way of actually reducing TSH receptor antibodies. And in those women, often we have a discussion with the surgeon, and quite a few of them go on to have a thyroidectomy. I probably would not recommend radioiodine in this situation. Propylthiouracil is safe during pregnancy. Like I said, I mean, nothing is ever devoid of any risks, but propylthiouracil is definitely safer than carbimazole in the first trimester of pregnancy. Often, if women still need anti-thyroid drugs after 16 weeks, we may go back to carbimazole, because propylthiouracil has risks not so much related to the fetus, but more risks related to liver function abnormalities. But luckily, in most women, we can actually stop all anti-thyroid drugs anyway from about 16 weeks. So often it's a non-issue. But yes, it is safe to take. Can postpartum thyroiditis be asymptomatic? Yes, it can, but does it tend not to be the ones that we see? Because the people who are referred to us are the people who've gone to their GP saying, I'm losing weight, I'm feeling hot, I have palpitation. The GP does a thyroid function test, and we find out that they have postpartum thyroiditis. But are there a lot of women out there with asymptomatic postpartum thyroiditis? Almost certainly, yes. When do TRAB need to be checked? I think we've answered that. So as a recap, everyone who's ever had Graves' disease, regardless of whether they still have a thyroid or not, at 12 weeks, if it's raised, or if you still treat it, if it's raised more than 3 times then, or you're still treated with anti-thyroid drugs at 20 weeks, repeat it at 20 weeks and repeat it at 28 weeks. For those things that I said, we need to know how closely to monitor your pregnancy and how closely to monitor your baby. How can you improve the chance of pregnancy with hypothyroidism, TSH around 3? So that TSH should be a little bit lower before you become pregnant. And if you're only on 50 micrograms, I would probably say that if that's your TSH level on that you increase that slightly, maybe to 75 in discussion with your doctor. I don't think this is your diet that does this, but I don't know if Xiao has anything else to add to that.
I mean, you can, I'm not sure that this is the appropriate place to give preconception counseling, but generally, you want to improve your vegetable, nuts, and whole grain intake, do regular exercise, stop smoking, stop drinking, sleep regular hours. But, if you've got difficulty conceiving, there could be a genuine medical problem, and you should go and see a doctor to discuss that with the doctor. Yeah.
So I think the next 2 questions are quick. What should TRAB ideally be before conceiving? Well, ideally within the normal range, but I think if it's less than 3 times the upper limit of normal, it is probably okay. Do I have women conceive even when it's higher? Yes, I do, and a significant proportion of them are actually fine. But if you ask me what's ideal, it's normal range, or what's acceptable is less than 3 times the upper limit of normal. But other women also become pregnant. You can take pregnancy supplements containing iodine, that's fine. Obviously, within reason, as long as you take them as prescribed.
No problem. Yeah. So the iodine that is contained in the regular pregnancy supplements are all within the recommended range doses, so there should be no issue at all. Yeah. Regards TRAB levels.
Yeah, I think I've just said that it's currently 1.9. I think it's okay to go ahead. I think
try
the
additional
question
iodine and
relates to that
selenium
as
before
well.
getting pregnant. No, there is no evidence that additional iodine and selenium. I mean,
No.
if your thyroid function is normal, you don't need to worry about those. And if you're worried about general micronutrient deficiencies, just take a prenatal vitamin that contains iodine.
There is no clear evidence that selenium really does anything. There have been a number of trials looking at selenium and whether that can reduce antibody levels. I think in some trials it shows that it reduces antibody levels, but it doesn't really affect thyroid disease. So I think overall the selenium trials have all been negative. A healthy diet and a normal pregnancy supplement will be fine. What is the reason why antibodies shoot up after radioactive iodine treatment? It's because after radioactive iodine, you get a lot of cell death. So essentially, you get cell death and inflammation in the thyroid gland because the thyroid cells take up this iodine, they die, and then the cells next to it die. And because of that whole thing, thyroid antibodies shoot up. And this is very clearly documented. And sometimes they can stay high as long as 5 years after giving radioactive iodine. There is no way of predicting this really. And that's the problem, which is why that is a situation, as I've said, we might recommend surgery.
So with regards to question on subclinical hypothyroidism and neurodiversity, well, if you take a whole group of children with neurodiversity, I don't think there is any evidence, we can't quantify how many of those are due to subclinical hypothyroidism. So I don't think we can quantify that, but we know that inadequate thyroid hormones can be linked to poorer neurological outcomes in the children. In one of the studies that have been done with subclinical hypothyroidism, it is a minority of children that showed some neurodiversity. Majority of those children were actually normal. I hope that answers your question.
It answers it for me. Does having hypothyroidism and being pregnant consider you a high-risk pregnancy? So, difficult question. I think if hypothyroidism is well controlled, or if you've previously had Graves' disease and your thyroid function is now well controlled or normal, you're probably not a high-risk pregnancy. If your thyroid function is very abnormal, then I think you are a high-risk pregnancy. If you need high doses of anti-thyroid drugs, you are a high-risk pregnancy. The fact that those women who are being actively treated have 2 to 4 weekly thyroid function tests means that we want to keep a close eye on it. I'm not an obstetrician, so I'm not quite aware of what's considered low, medium, or high risk. But you know, even within that population, we would have a gradation. But well-controlled hypothyroidism in pregnancy, even if you're actively treated with anti-thyroid drugs, in the vast majority of cases will have good outcomes. But it's about keeping a close eye on things and treating as appropriate.
So the question about luteal phase spotting, you know, that is not usually due to the thyroid problem. The important thing is that if your thyroid is well controlled and your thyroid function is within the normal range, then it hasn't, it's not the reason for your luteal phase spotting.
I think we have answered all the questions. I hope we have.
All within 1 hour.
Exactly.
I think it's absolutely incredible. Thank you so much. We are so fortunate to have such international experts speaking to us tonight and answering about 50 questions. So it was like it's like one of those quiz shows where you have to kind of get as many questions done before the buzzer goes, and you've done it before pretty much within an hour. We're really, really grateful for you. I've just got a couple of slides to share about BTF before we finish. One of the questions we had right at the beginning was actually the importance of getting GPs on board with all these important messages that you've been sharing with us tonight. And as Christine mentioned, that we'll be doing a webinar with an online platform for GPs, and you know there are well over 400 people that will be attending that. And the BTF also will be attending the upcoming RCGP event this year, annual GP meeting next month, and we'll be giving out a lot of information to the hundreds of GPs who attend that. So again, we'll be doing our bit to share these important messages with the people who really will be able to help you if they know more about them. So this is, if there are any healthcare professionals on the call, this is the event they'll be doing that's online that Christine will be speaking at, and this is the QR for the joining code. And finally, I'd just like to let you all know, if any of you are kind of inspired by the back to school feeling we're all getting this first week in September, and you'd like to do some fundraising for the BTF to support the work we do to be able to put on events like this, we have an annual event called Stride for Thyroid. If you'd like to kind of get out and about and do a little bit of fundraising for the BTF, that would be enormously well received by us. Thank you very much, everybody, for attending today's event. Thank you, of course, the speakers for giving up their precious time. You're super busy people, and we really do appreciate all the work that you do to support thyroid patients and putting on events like this. And thank you to all the people who attended the event and all the amazing questions, the range of questions that you put on. Those are all really useful. Hopefully you felt your questions have been answered, but most importantly as well, we've all learned from the questions you've put on the chat and they've been answered tonight. Thank you, everybody, for giving up your time to come to this event. It will be, if you'd like to listen to it again, it will be shared on our YouTube channel and on our website. And we usually try to do a transcript, transcribe all the questions that come up. So that will be a document you can refer to as well, just to go through the questions. We look forward to seeing you at future events. Thank you very much.